Great. Thank you so much, Kelly and Chandri, and also Erica Poling, who is the coordinator for ECHO on the rheumatology end. It's such a pleasure to get this ball rolling, and we hope that this will be a long-running series, and hopefully it will be helpful to people. This is a very general introduction to kind of some of our processes, even how we handle referrals. I'm very open to questions. I have cases at the end if people want to discuss those, but we'll also give you an opportunity if you have a case that you want to talk about today. I think that would actually be fun. We do have a formal way of doing that each week, and so we can get them ahead of time, but I think if we can do as much of a discussion too, that would be fantastic. So thank you all for being here. All right. And I think first and foremost, what we're trying to do in rheumatology now, as we're growing in Morgantown, is to increase engagement with people in the community. We're all engaged in taking care of the same patients, and we want to do the best we can for them in this kind of resource restricted environment. And so I've put my email up there. Please don't put patient information in those in emails, but if you want me to reach out and call, that would be a fine way to do that. And then Epic staff messages are great. The Mars line, if you have questions. And then I wanted to highlight this resource that's called roomforprimarycare.org. And that is from the American College of Rheumatology. And please be patient with them. It's a little bit wordy and word heavy, but it actually can guide you through symptoms and maybe what labs you'd want to order. It's got some case studies on there. So it might be worth exploring if you are looking for another rheumatology resource, and that's free, and you don't have to sign up for it. So looking at Project ECHO more broadly, even outside of WVU, and I was looking at what their mission statement is, and really to improve care for underserved communities by demonopolizing specialty knowledge. And I really love that idea of demonopolizing specialty knowledge. This is group knowledge, and it's we're happy to work as consultants, but also there can be a great benefit to patients when we are more collaborative with primary care communities. And so that's what we're looking to do. And right now we've got WVU rheumatology throughout the state, but you can see there's large swaths where we really don't have a presence. It is growing, though. We will have rheumatology in Wheeling, probably starting in January, Martinsburg, Shepherdstown. So call out to the folks out there. And they're wonderful providers in that area. And then Morgantown is growing. We now have 5 MDDOs and 2 APPs as of July. And then we'll probably be adding 2 more next July. And then we also expanded our fellowship. So we'll have 4 fellows. So we'll probably be up to at least 11, 13 providers starting next year. So that's pretty exciting for us. And this will be second Thursday every month, as you know. And we'll try and keep the topic to 20, 30 minutes. Happy about the cases. And then I think for us as well to just grow and do a better job as we go, we will be having some sort of evaluation, and whether that's just numbers or, but we also want feedback. And it's always okay to just send me that as well. And so what is a rheumatologist? So we've just got training in treatment of musculoskeletal diseases and diagnosis. And we focus mostly on inflammatory and autoimmune diseases. So part of the issue that we have in rural areas, and I've worked in rural medicine pretty much my whole career in one version or another, and 10% of rheumatologists work outside major metropolitan areas. So very limited access in rural areas. And because of the aging population, increase in autoimmunity, and actually a lot of rheumatologists are on the older side, so there's a lot of retirement going on. And so the need is probably going to double by 2030. And so, as I mentioned, we focus on the autoimmune diseases, rheumatoid arthritis, lupus, psoriatic arthritis, vasculitis, inflammatory and autoinflammatory diseases. A lot of those are in childhood, but things like gout, CPPD, VEXAS. And if you're interested in VEXAS, we're doing a talk on that in the Dr. D conference tomorrow. And then infectious arthritis, so things like Lyme arthritis, sexually transmitted infection related arthritis. And we get a lot of referrals. So we probably get over 250 referrals a month. And we do screen all of those. And so if we do send a deferral letter and someone feels strongly that that patient should be seen, we do want to know that. And that will help get a patient seen, because we're not on the front lines, and we totally understand that. And so our view is sometimes narrow, and so just some sort of communication, hopefully not too complicated on your end, because we're not trying to create work for referrers. As it stands now, because of the large volume of referrals and limited resources, we don't actually tend to see patients who have chronic pain and fibromyalgia, hypermobility, those sorts of things. So, and the referrals don't have to be long, and the referrals are all reviewed within a month. Sometimes we're completely caught up, but the longest time it goes is about a month. So if you haven't heard back in a couple of months, some of the referrals do get dropped from the queue for various reasons. So please let us know if there's one that's outstanding that you haven't heard about. And then if individual patients require, we do send them back, inquire about their referral. We send them back to the referring provider. So, and the things that are most helpful in the room referral: history, and I'll talk a little bit more about that, physical exam, and then any treatments that were tried, and labs. I think if we're going to include any labs, sed rate and CRP are probably the most helpful. And it doesn't have to be a complicated workup prior to sending. And, you know, a CBC, especially if you're thinking about lupus, creatinine, LFTs, uric acid if it's gout, and then any specific workup. So, and then any imaging that was done. And then for the room history, the things that are helpful are really helping us tease out, is it inflammatory or non-inflammatory joint pain? And these are the typical things: the onset, duration, timing, remitting and exacerbating factors. And if there's a pattern of joint involvement, like is it large joint or small joints? And then the distinction between inflammatory and non-inflammatory symptoms. So if there's warmth or redness or swelling or pain, and especially stiffness in the morning that's lasting more than 30 minutes, can be one of the most helpful signs that we have. And then any associated systemic complaints that we would see as well. Rashes in particular are helpful. And we've started a clinic with dermatology. So we have a combined derm room clinic once a month now. And so if patients are in with rheumatology or in with dermatology, one or the other, we can get people into that clinic as well. So it's another pathway to get people seen pretty quickly. And we see them together at the same time. And most patients seem appreciative of that option. They do have to be established with either room or dermatology for that to happen. But it can often expedite a biopsy or treatment for derm if we need that. And these are just some of the features that would make it inflammatory versus non-inflammatory. Synovial fluid cell counts are super helpful. A lot of the times it's ortho who ends up doing those because sometimes orthopedics is more available than rheumatology. But these are some of the features that are most helpful for us. And then on physical exam, um, rashes, joint exam, oral ulcers or dryness symptoms like sicca. So dry eyes, dry mouth can be very helpful. And then any lung findings, crackles or ralls, and then weakness, especially proximal weakness, can be very helpful. And any mention, and when I'm looking at a referral, any mention of a joint exam, I definitely appreciate because it can be one of the most helpful things when people mention that they think that they're swelling or synovitis. And so, and synovitis feels rubbery. If you put pressure, the right amount of pressure is probably until the thumbnail is blanching, like in the picture here. And then if you think about the MCP joints, the joint space is more anterior than directly on top of the knuckle. And then, firmness is osteophytes. I personally love osteoarthritis, so I will see a lot of that. But sometimes that can be seen by ortho too. And this is just some examples of what swelling looks like in rheumatoid arthritis. And further on through this series, we're going to have talks that are specific to certain disease processes. And uh, when the Echo folks did the survey initially, that seemed to be what people wanted. And so we are focused on that and throughout the series. But if there's other topics, we would love to accommodate that. And I'm all for expanding this series if case discussions are what people want. I'm happy to do that too. So this is really rheumatoid arthritis. It's boggy. To me, it feels more like a water balloon when it's really active. Sometimes it's chronic and it's thicker as well. But you can see in the PIPs here. I don't know if you can see my pointer, but right here and here are some places where there's a lot of swelling. And then in this patient as well. And these are probably rheumatoid arthritis. You can also see loss of the contour here. And even though we talk about it being a small joint symmetric arthritis, it often isn't symmetric exactly. People often have more on one side or on the other. And as opposed to this, which is more of an osteoarthritis picture with these Bouchard's and Heberden's nodes, and deformation. And a lot of patients will associate the deformation with rheumatoid arthritis, and especially with family history. So family history is even more important in osteoarthritis and more likely to be hereditary, especially in women and especially hands, than rheumatoid, which has less direct inheritance. So, and usually we use the labs to support the diagnosis, and often the diagnosis is more clinical, especially for rheumatoid arthritis. And so, as I was saying, the most helpful ones are probably the SED rate, the CRP, CBC, creatinine, and a urinalysis, especially if you're wondering about vasculitis. And then antibody testing, really based it on what your clinical opinion is. And, a rheumatoid factor and an anti-CCP antibody can both be helpful. I think in the session on rheumatoid arthritis, I'll probably talk about those in greater detail. But the anti-CCP antibody is more specific for rheumatoid arthritis than the rheumatoid factor, which overlaps with certain other disease processes, particularly with Hep C. So I pick up a lot of Hep C in rheumatology clinic. So, and then the ANCA can be helpful if you're suspecting GPA or some of the other forms of small vessel vasculitis. And then an ANA, even though we see those commonly, they aren't a very good screening test due to the test characteristics. I'll talk a little bit more about that, and I think later on in this series I'll also talk about that more. And then others like uric acid, the CK, LFTs, a Lyme, and I will repeat Lyme if it was checked once and someone has symptoms, particularly large volume knee effusions, and I will repeat it because there is that window period with Lyme, and sometimes we see them seroconvert. So I'm probably less strict than ID about Lyme disease, so and about treatment for it. But all of these things we picked up in rheumatology clinic, and so some of them do have arthritis manifestations or other systemic manifestations, and then synovial fluid when possible, especially for crystals. And CPVD crystals are difficult to see, and so it doesn't necessarily 100% rule out if you feel like someone has pseudo gout or calcium pyrophosphate deposition disease, then even negative crystal analysis does not necessarily rule that out. And then imaging as people feel appropriate. And then skin biopsies in particular are helpful. So I mentioned the ANAs, and so times to order it is when the suspicion is pretty high. If someone has an inflammatory arthritis, that's a reasonable time to check it, and then any accumulated symptoms will increase the pretest probability, and like a rash, especially a photosensitive rash, sometimes on the face, but other places too. Inflammatory arthritis, cytopenias are a good time to check. So leukopenia is definitely associated with connective tissue diseases like lupus, and then dry eyes and dry mouth. It doesn't necessarily have to be in the mornings; it can be all day for those. And then if it's a younger patient and they have juvenile idiopathic arthritis, an ANA is really important because that helps with prognosis, and they will need to get eye exams based on that. So the problem that we run into is that the ANA is not a great test if it's positive at low levels, and usually that's like 1 to 40, 1 to 80 with the titers. And there's two versions of an ANA. So there's a direct, and that one just comes back as positive, and then often it will reflex to the other types of antibodies. And then there is one that's called an indirect. And the indirect one is more helpful. So if you have the choice of choosing, choose an indirect because it comes back with the titer. And people can have a low titer for a lot of different reasons. There's cross-reactivity, particularly with thyroid disease. So we'll often check thyroid antibodies as well. With autoimmune liver disease, cancer, and we try to avoid even checking them when people are in the hospital if they have an infection, because their immune system's revved up and they might be making an antibody that will then go away later on. And then Raynaud's is a very, very good reason to check an ANA, especially if it's an older person who has new onset of Raynaud's. So, and we usually won't see if the ANA is 1 to 40, we probably won't see somebody for that reason. But if and at 1 to 80, it'll depend on what the other symptoms are. But again, we can be wrong, and we don't want to miss somebody who we should be seeing. And then it's actually a great test if it's negative. So very rarely do people have ANA negative lupus. So there are cases of that, and there are studies where people had ANA negative lupus, and it's been seen as a drawback to some of the studies, but very low likelihood of systemic sclerosis or lupus and other connective tissue diseases, and and systemic sclerosis also, if they don't have Raynaud's, very very low risk. So and the titer, one of the reasons that we try to get the indirect ANA in and the titer, because that's really more helpful to us than the pattern. And there's the patterns, again, like the test itself is not very specific. So the ones that are specific are centromere and nucleolar, and those are specific for systemic sclerosis. But most of the patterns you can see with anything. But if it's a high positive ANA, that is definitely somebody who we'd want to see. And they may not have disease at this time, but the antibodies will predate developing disease. So we often follow them, especially if they have some other features. And then we don't follow the ANA over time. Once it's positive, we say it was positive, and then move on. There's other ways, sometimes limited, definitely not perfect, of on how to monitor disease activity. So those are the things just about referrals and the basics. And as I said, history is a key feature. Everything else is supporting, and please reach out. And then one thing, I saw somebody from Minnie Hamilton here, so I just want to put a plug for the TRUST trial, and which is looking at gout treatment. And I think our next session will be on gout. And the TRUST trial is a trial that's run out of Mass General, and but it's being done in primary care offices in West Virginia, which I think is an amazing model, and I'm so excited to just be just a consultant for this. But looking at how rheumatologists treat gout versus treating it symptomatically. So there are professional societies who have opposing goals on how to treat gout, which makes it very confusing. And we really don't have head-to-head trials to tell us what's the best way to do that. And we do see a lot of gout in West Virginia. I've seen some of the most severe cases of gout from my career, which has been truly disabling for people. Large burden of tophi, and we're happy to see them as well, and we can get them started on Krystexxa. It takes a little bit of time, but it does happen, and patients over time really do improve with that, even if they haven't been treated or they have very difficult to control disease. So hopefully the TRUST trial will continue and continue enrolling. So I have some cases. Does anyone have a case that they'd like to bring up, or a question, or things that they'd like to see in the future? So go ahead, and you can put it in the chat or yell, raise your hand either way. And we're going to go on to some cases. Yeah, one of the most painful things ever. So I appreciate that, and anything that we can do to help, we would like to. So this is an example of what we see pretty frequently in rheumatology. People will get sent to us with rashes, and sometimes they've been biopsied and sometimes they have not been. And this is something that we would be happy to see. And it's okay to give us a call to get this patient in quickly. We do any of our urgent referrals should be triaged right away. We have a referral coordinator who's supposed to be pulling those out and making sure that they get in front of us right away. So we try to see that, but if you feel like it's been too long, do let us know because we will try to see somebody who has something like this right away. And so just thinking about it, like any labs that anybody would order in to help work this up? Yeah, I think it's I would say vasculitis. Yes, absolutely. All of those, the sudrate, the CRP, and the CBC. And I would expect this person to have elevated CRP. Um, so, all right. So, and so we are happy to see this, and we'll try to see it quickly. And because we can't tell, right? Even if the CRP and saturator are elevated, it could be infection, it could be autoimmune, sometimes malignancy. If we can get them in with derm, and I've had derm see people the same day, so sometimes we can also just advocate for somebody when they're coming from rheumatology clinic, and we say, "Oh, we think they have vasculitis." Derm is pretty helpful, whereas sometimes they might have to wait longer on the outside because the skin biopsy can be very helpful. And if this person's hemoglobin was about 11, their white count was a little bit low, and they had a low CRP and an elevated sed rate. And that can be helpful because that we see in lupus. And for some reason, the CRP, which I won't go into the details, is sometimes low in lupus, but an elevated sed rate. And then this person had a little bit of an elevated creatinine and a UA that showed blood and protein. So obviously, that kind of gets everybody's attention as well. And then the ANCAs, which we would check in that situation too, were negative or normal, and that includes the MPO and PR3, and then the ANA in this setting was positive, and at 1 to 640, which is a pretty high titer, and then the complements, both the C3 and C4, were low. So, so this is leading us to maybe a case of lupus vasculitis. And so lupus is heterogeneous. It's multifactorial systemic autoimmune disease. And it's what we call loss of tolerance to self antigen. So people make autoantibodies. And there can be a lot of different proteins involved. And and really, the T and B cells are not working as they should. And so it leads to antibody production. And then what happens is you get these complexes or clumps of um, immune cells and antibodies, and it goes into the tissues, and complement gets activated, and it creates an inflammatory pathway, and so complement gets used up, so it goes low. We actually don't worry too much when complement is high. So and so and I will get to that question in a second. Um, so, and after I finish this case, and then before I go on to the next one, I just stacked it with cases in case people weren't bringing things up. It sounds like people have things to bring up, and and lupus is very wide ranging. We will have another talk on it in more detail. And about 50% of lupus patients get vasculitis, but they don't often have systemic involvement with that. So skin lupus can be all by itself, and don't worry if it's got a negative ANA, but you think somebody has skin-based lupus because it can. The ANA can be negative, and this would rarely involve the larger vessels like the aorta. All right. So I was just reading this. She has joint stiffness and swelling and rash, and she can't seem to get. Hopefully that's okay for me to say that she can't seem to get a rheumatologist.
Yeah, when they call to get when her PCP calls to get appointments for her, they say if she doesn't have a diagnosis, then she can't, like a rheumatology diagnosis, but she's really trying to get to the bottom of what her issues are. So